This talk came about really from the beginning of my involvement in ISSG. Let me see. What am I not? What's this one? There we go. So this was a concept that occurred to me actually a number of years ago, following complaints from patients that I'd fused. Usually, those were patients that I'd fused thoracolumbar junction to the pelvis at that time, and that length of construct really resulted in some patients that came back very unhappy with a resulting loss of function. The function that I heard about first and most bitterly was the loss of perineal care ability, so the ability to wipe after toileting, and that kind of led me to look more closely into this. I start this talk with this phrase, which is one that I like to use with our fellows and residents and students, I think, and it's something actually patients need to understand, right? So patients come to us a lot of times in desperate situations and ready to really do anything to try to improve their situation, and I think their concept of what surgery can do is different than those of us who actually practice this and know what it looks like in the operating room. So no matter how we do this, no matter how minimally invasive we are, we're creating some form of injury when we operate on patients and doing it in a controlled fashion, but it is in the end controlled injury, and I think it's important to share that with patients. So from that we developed the concept of what I call the collateral outcome. So this is an outcome from surgery that's going to be adverse. It's something the patient doesn't wish for and we want to mitigate or avoid, but it's typically an unavoidable consequence. It's certainly something that when it happens, we as surgeons look at it and say, well, that's just part of the deal. When you start to think of things in that way, you realize that there are a number of things that kind of fall into that category. And as I looked into this further, I also found that there was an article written that has very much the same concept by Clavian and a surgeon named Steve Strasberg, who's actually a friend of my wife's. He was a hepatobiliary surgeon. He was at Toronto when they worked on this. He's been at Washington University in St. Louis now for a number of years. But they have a classification of complications that gets referred to frequently, and they included the most mild on that list as what they called sequelae. And what they're talking about, again, is the same sort of an idea. This is just something that's part of the package, and you're going to have to accept this in trade-off for the proposed benefits of the surgery. So if we think of that in the context of spine surgery and maybe orthopedic surgery, iliac crest bone graft site pain, almost now, of course, a thing of the past because we almost never harvest this, but back in the day, we used to do it all the time, and by God, that hurt, right? And at the end of the recovery, if it still hurt, we said, sorry. And the patient said, yeah, that was the worst part of it, but hopefully they said thank you. But it was a common issue, no matter how well and how uncomplicated the graft harvest was. Swallowing impacts after cervical fusion, those are a common complaint, right? A lot of times those are temporary, but they're certainly something that we hear about, and in some patients those are permanent, and we really don't have a good explanation other than, well, if you dissect behind the esophagus, some people come back with a swallowing issue. We know that posterior lumbar surgery, if it's done in an open fashion from the midline, we really are essentially killing the paraspinal muscles, so they do not survive typically, and if we look on an MRI, we see that they've been devitalized, and they may not any longer need to function in somebody who's had a fusion. At the same time, there's probably some loss of function that comes with that. Anterior knee pain is what I put on here, thinking back to my days as a resident, putting in an intermedullary nail for a tibial fracture. A lot of patients didn't like the insertion point and felt pain there. And then the one that's most relevant to this talk is the loss of motion following joint arthrodesis. And we know if we have to do a salvage procedure such as a knee fusion or a hip fusion, that's really in and of itself, it's disabling. There's a disabling aspect to that. That's far from perfect, but there are patients who are willing and need to trade whatever motion they have in order to have that more pain-free, albeit stiff joint. And at this stage of the game in spine surgery, that's still for patients with multi-level disease, that's still what we're offering is arthrodesis, removal of motion. So I felt there's an important need to kind of define and measure how that affects patients post-operatively. If you look at the way we've conducted clinical outcomes research over the last 20 years, we've really focused on developing validated and repeatable measures for these patients, and I think we've done a good job, but we really have been focusing on what are the clinical benefits. We're really asking them about pain and function, and particularly, and to some extent, deformity and appearance, but we're really after their input on how are they benefited by the surgery, and we really have not developed questionnaires that ask, how have you been negatively impacted? And I think this is coming out now, is going to get wrapped up even further into questions of what are your expectations, what are your desires. So patient-centered outcomes that really involve the patient in defining what's important to them, I think is going to be part of our practices going forward. So the background then is, while pain is a relevant parameter for these patients, there are other issues that may affect function and satisfaction, and many patients have questions regarding the expected loss of motion when you start talking to them about a fusion. And that's almost always, it may not be the first question out of their mouth, but I think almost every patient, even if I don't suggest, it is a stiffening operation, they already have that concept. And I get asked that almost 100% of the time. How is it going to affect me once you fuse? And for us, thinking of 1 or 2 level fusions, we think, well, that's no big deal. And it probably isn't. And in fact, I think the data now supports that it isn't. But it is to patients. They come in thinking, well, if you fuse that one disc, how am I going to be able to walk? How am I going to be able to bend? And it is true when you fuse the entire spine that you do begin to see some functional impacts. And I do think that we find in long construct patients, there are patients who are bothered by these issues. This was one of the first patients that I operated on and really heard about this, and we ended up writing up a couple of papers. This first one was a very small case series that a medical student wrote with me years ago about this issue, and this was focused just on perineal care because that was what I was hearing about. The x-rays there are from a patient that we did a T10 of the pelvis fusion for adjacent segment disease, and she came back very unhappy and then ended up with a non-union above, and I offered her a revision fusion, but she was happy that she had the restored ability to perform perineal care functions. This is before. Now there are, of course, assistive devices, by the way, on the internet. I think it's called the Bottom Buddy, and I have no conflicts of interest with that device. But at that time, those didn't exist. So she was bitterly unhappy about that. On the right is a page that we wrote up as a case report that came out after that paper, and this is a woman who we had done a successful and solid fusion on, and she was actually self-inserting a rectal suppository after that and developed a compression fracture in the middle of her construct. And to me, that indicated, well, that function requires some lumbar mobility. This was actually asymptomatic and didn't really change anything, but I thought it illustrated the idea. To shed a little light on this paper, when we submitted this, and I had to submit it about 3 different places before I finally got it published, nobody was interested in it, and we ended up in what I consider not the top tier orthopedic journal, but I was happy with that. But at a certain point during the review process, one of the reviewers said, well, the authors should have developed a validated questionnaire rather than just use, we had like 4 or 5 questions. And they said rather than use that, they should have developed a validated questionnaire. And when I first got that concern, my initial response was, well, that's stupid. But then as I thought about it and it kind of continued to resonate going forward, I decided, well, that's actually a good idea. And maybe instead of focusing just on the question of perineal care function, we could create a questionnaire that really encompassed multiple physical functions to try to assess how much stiffness in the lumbar spine takes away from ability to perform those functions. So again, these issues play out in different ways, and I think they may begin to interfere or to inform our decision making with our patients. And this was a patient I operated on years ago. I think she would be a candidate potentially for a thoracolumbar to pelvis fusion. She's got 2 really bad discs, and she's had a very rapid coronal plane deformity develop, and she's disabled by back and leg pain as a result of these, and she's a ballet instructor. and this is what her MRI looked like. And you can see the discs in between are healthy, and so it's kind of a shame to fuse those segments, and that was the concept that we followed at the time. And I did an operation then that I think I've repeated one time since then, but she had a fantastic outcome from this, and it was very important to her to be able to continue to teach ballet, to continue to have lumbar flexibility, and this was the only way I could see to treat her ongoing disability and not take all of that motion away. This was her at 3 months in my office, and she's a redhead, and she has the behaviors of a redhead. She is an active and fiery woman. I've lost touch with her now over many years, but I followed her for about 5 years, and she remained very happy with this as an outcome. And again, this is without an ability to really have data to inform that conversation. Here's another woman that I think this is a 1 or 2 level problem, really above a prior 5-1 fusion with a scoliosis and stenosis at 2 levels above. You could conceivably shorten this construct, and we talked about that. It's not a very big curve. There isn't much sagittal deformity, and this was a nurse, but she said, I want one and done. I want the most definitive procedure. And so for her, again, without knowing really the clinical impact in terms of stiffness functions, and particularly in young patients, we went ahead and did this operation, and she ended up satisfied with this as well. But I think it's an issue where we'd be better off with better information to share with our patients. So that led us to develop what we called the LSDI in kind of analogy to the Oswestry Disability Index. So this is a stiffness index that has 10 questions, again, looking at functional limitations specifically attributable to stiffness as a cause. So 10 questions looking back at how does stiffness affect this. So the first question is, how are you affected in terms of your ability to bend to your feet, to put on underwear and pants while dressing independently as a result of lumbar stiffness, and 0 points if there's no effect at all the way up to I cannot even do this because of low back stiffness. And the rest of the domains are these. Some of these are shared by the ODI, others are not. And we tried to think of and incorporate topics that we had heard about from patients or that made sense that they might be affected by stiffness. And once we had the questionnaire developed, we went through the process of validating it and proving that it is reliable and repeatable and internally consistent. And the internal consistency measures how the questions travel together. So a patient that has a low score on one question, you would like to have a low score on other questions, high score on one question, high score on other questions. And it turns out that is the case with these questions. They tend to travel together. The interclass correlation was the repeatability, which ended up to also be quite high at 0.9. So overall, we felt we had a questionnaire that we could rely on to some degree. And this is the data for the retest reliability, and you see that it is 6 weeks apart. The patients score very similarly to their original score. And we then looked at a form of external validation, which was using flexion extension films and asking patients for their level of effect. And this was all retrospectively done, and not a huge correlation, not a perfect correlation, I should say. But we ended up with an R value of 0.71. And I collaborated with an epidemiologist, Lynn Marshall at OHSU, on this data. And this was really enough to hang our hats on that, yes, it is some aspect of lumbar stiffness or loss of motion as measured by voluntary radiographs that seems to correlate with higher scores. So that's a form of validation. And then after that, we wanted to get some data on some normative data, asking patients how are they affected by stiffness. And this was something we conducted actually through ISSG early on in our activity, and asked a number of patients with scoliosis and then that underwent operations. That's what this line is. These are the ones that have the highest effective stiffness, by the way, even though they had not had prior fusion surgeries. These are patients that were in our cohort that were chosen non-operative. So you can see that there is some aspect, and that was borne out, by the way, in the terms of the ODI. They also had lower ODIs. So they had less pain, and the ones that were chose non-operative treatment also had less effective stiffness. And I think it's important to recognize that these patients that we're operating on already attribute a lot of their disability to stiffness, and I think this actually addresses the question that you were talking about earlier. So they're not using their backs by the time they come to surgery in a large degree, and that actually also influences how much effect the surgery actually has in terms of stiffness. But if you look at people without back problems, very low score. So again, this is some form of validation, and it gives us some information to compare to as we start to look at actual clinical outcomes. So we did a couple of studies as a single center at Oregon, one retrospective and one prospective. These were the results of our retrospective study using this questionnaire, and we correlated it also to ODI. And what we found was that as we increased the numbers of levels fused here, so 1 through pan-lumbar fusions, we found that there was well, this shows that these were actually, there was a matched cohort across the numbers of levels fused. But when we looked at the actual ODI and LSDI scores, we found that the LSDI separated a bit, and you see that we did have higher than normative scores for even a 1-level fusion, but clearly much more effect and kind of a stepwise progression as we increase the number of levels. Whereas for ODI post-operatively, we were relatively uniform across the entire cohort, and there were no statistical significant differences within the ODI scores, but in fact, when we compared the 1-level fusions to the 5-level fusions, there was an increase in stiffness-related effects as we increased the number of levels fused. So at that point, we felt we've got a valid, consistent, reliable tool, that we do think that functional impairments due to stiffness is an important collateral outcome, and that patients with significant degenerative disease, even without fusions, do report significant stiffness limitations, and that the LSDI and the ODI, while correlated, are not duplicate measures of disability. So with that in mind, we went ahead and started a prospective clinical evaluation, and this was extended out over a 2-year follow-up with, again, multiple diagnoses and multiple numbers of levels of fusions. And different types of procedures in terms of anterior or posterior only, with more combined procedures in the higher numbers of fusion levels. But other than that, a fairly matched cohort across the enrollment. And we found that the fusions, the ODI and the PCS scores improved significantly in the entire cohort, no matter how many levels of fusion. So across all of the numbers of levels of fusion, and you can see we had a fairly limited number that we did 3 or 4, so we combined those. But in fact, the only significant change that we saw in the LSDI reporting was this group, the 1-level fusions, and they actually said they got better. They're less stiff after a 1-level fusion, or they perceive less stiffness. And again, it gets back to the effect, I think, of pain versus stiffness in how they're experiencing the function of their lumbar spine. And this is what that data looks like in graphical form, and I think it kind of presents it in a little more compelling way. This is the PCS where a positive change is positive, and the ODI, a negative change, is positive. The LSDI is similar, a negative change is positive. And we see that there's a statistically significant change here as a reduction. There is a trend towards an increased score in this group of 5 or more fusions, but this did not, in fact, quite reach statistical significance. And these are just a couple of examples. This is a one-level fusion in that case for, I think this is, it's a degenerative disc disease, an operation that is increasingly hard to get authorized and one which I increasingly and frequently do in my practice. In fact, I think I've had one in the last year. But this gentleman had a substantial decrease in his LSDI. We still don't have a measure of the clinically important difference for LSDI. We've never taken that step. Not sure at this point that's necessary, but he did have what looks like a fairly substantial change in LSDI and a nice change in the ODI and PCS as well with a one-level fusion. And this is an example of an upper thoracic to pelvic fusion. And she did notice a slight increase in her LSDI scores, but a better decrease in her ODI scores. And we tried to get at the satisfaction in these patients as well with these three questions. So do you consider the low back stiffness to be a significant limitation, just to see, do you in fact perceive that as an issue? But knowing what you know now, would you do the same procedure again? And do you consider any low back stiffness that as a result to be an acceptable trade-off for the improvements in pain and function? And this came out really, I think, where you would hope it would be as a surgeon, with very high, a fairly high percentage saying yes, they are affected by stiffness. But if you look at satisfaction and trade-off, nearly 100%, 90 to 100%, they would do the same operation again, knowing what they know now. And when you ask specifically about stiffness, a little bit of a dip here. This was due to one patient who had a two-level fusion and was unhappy. But other than that one patient, again, 90 to 100% willing to accept the trade-offs that the stiffness creates. So to update, we now know that perceived stiffness appears to be no worse for 1- and 2-level fusions. That data has not been updated in any other cohorts, but I think it does at least give us something to hang our hats on. It is prospective data, and I think it does allow us to inform our patients of what they can expect. As we increase the number of levels, we may see increasing impacts, but overall satisfaction remains very high despite those effects. So as I entered the LSDI, and I guess that's been, 12 years ago now, and at our very early meetings, we were really kind of just creating our group and kind of deciding what we wanted to do. And I had this questionnaire, and I said, hey, what do you guys think? Do you want to include this in our outcomes questions? And I think naively people in the group said yes without thinking very much about it. 10 more questions, what the heck? And so we did it. It's no longer part of the questionnaire package because I think we sort of answered the questions that we wanted to with it. But I was delighted that my colleagues in the group were willing to administer it. And so we were able to develop a large prospective database of patients who were queried pre- and post-operatively regarding these issues. And when we've looked at that data, again, well-matched preoperatively in terms of their LSDI scores. These were two groups looking at the effect of, if we stop at upper thoracic versus thoracolumbar junction, does that have an effect? And that was yet another unanswered question. But similar baseline data, and when we look at them post-operatively, again, at 2 years, all of the traditional scores significantly improved from baseline, but the LSDI, not a lot of change. And it was true over the upper thoracic, where the delta is only 2.4, and the thoracolumbar, actually a slight decrease. And in both groups, no statistically significant change in the perceived impact of stiffness on function. So again, I think we begin to be able to inform our patients what they can expect. And these are a couple of my own patients out of that cohort. This gentleman, a thoracolumbar fusion, mainly for sagittal deformity, and this patient, one with an upper thoracic, and in both cases, fairly limited change in LSDI score from pre to post-operatively, and particularly in comparison to the extent of the change of their physical function and pain scores. And we didn't have quite as robust a measure of satisfaction, but we've used the satisfaction score out of the SRS questionnaire, which is really just 2 questions, and does ask actually something along the lines of, knowing what you know now, would you do the same procedure again? And there was almost no correlation with the baseline, with the 2-year postoperative LSDI score. So even patients that have very high LSDI scores, a lot of disability from stiffness, still turn out to be very satisfied, or at least equally satisfied with their outcomes. So this doesn't seem to drive satisfaction with their decision to have these procedures. And so since we've completed all of that and published some of that data, we've begun to get some interest from other colleagues in extending this to other populations. And this was yet one more question that I had in mind as one that was important in deformity. Back then, I think it was more common to stop at an L5 endpoint. I think certainly in my own practice, even with a healthy L5 disc in an adult patient, I'm usually going to include that in the fusion and include pelvic fixation these days. But I think it was a legitimate question: does preserving L5S1 affect these outcome scores? And we had a colleague from Germany, Heiko Kohler, called me and said he had some L5 patients and he was interested in this question. And so we went ahead and culled that data. This is retrospective, so not quite the same level of evidence, but almost no difference if we stop at L5 in terms of their 2-year LSDI versus going all the way to the pelvis. So very similar in terms of their overall stiffness effects. So it doesn't appear to be an argument for preserving the L5S1 disc if we're going to do a pan lumbar fusion outside of that disc. So I've given this talk in other contexts in front of residents and fellows. I guess since my fellows are here, it's still relevant to instruct you guys to respect your teachers. And I think it's important that we all learn from our mistakes. And some of these things are not mistakes. I would maybe generalize that more broadly, which is to learn from your patients. And I think your patients will teach you things that your teachers have not, all right? And this is certainly an example of that in my own practice. And with that, I'll acknowledge all of my coworkers, Lynn Marshall, Jamie Haratzka. Kenny Gundel was a medical student at Harvard who came out and worked on this with me, is now a faculty at OHSU. Alan Daniels was one of our medical students at OHSU, is now an orthopedic surgeon faculty out at Brown University. And then Stefan Pro, again, one of our residents. Heiko Kohler, I've already talked about, and Marie Kane was our manuscript preparer, and of course all my colleagues from ISSG. Thanks very much. Ted.
I think that's a great paper, and it's a true learning experience. Always. I think one of the great, 2 comments, one great example for you is Dr. Ng and Bullhorn. He was operating on divorce. He himself has achondroplastic deformity. And what did he find? If you fused the achondroplastic, he couldn't take care of his perineal care. And he had to lengthen the arms first. So that's the most dramatic example for your discussions, because I think the outcome is absolute. Mm-hmm. So that's a great comment. The second comment is, as we look at juvenile scoliosis, or we look at adolescent scoliosis, in which we have a right thoracic curve and a left lumbar curve, and normal discs in between. Should we go and experiment with doing short correction of both curves, leaving it open in the middle? And would that lessen our stiffness, or maybe give them more function? And I've done a couple, and I must tell you that it hasn't worked out perfectly. But it is, I think, a concept that has to be really looked at.
Right. Well, I showed you, so I'll take the second question first. So I showed you that one patient. It's a different issue, but two separate fusions. And, I've shown that in various audiences, and it's far from uniform that people say, yeah, that's a great idea. There's a lot of surgeons say, yeah, I don't know how long that middle disc is going to last. But the truth is, none of us know, because none of us do that operation very often. And, in that patient's experience over the course of time that I took care of her, which was, it was up to 5 years post-operatively, she really never turned a hair in that middle disc. So whether there's going to be a role for more selective fusions, I don't know. I think time will tell. The other question in terms of the dwarf, I mean, that's something we've actually talked about, is there is some aspect of sort of limb-trunk ratio that probably affects the overall level of function. And a counterpoint to all of this is and I think probably most of us, I can remember a woman who came in that we'd done a thoracolumbar to pelvis fusion, and she was showing me at a year or two post-operatively she could bend over and put her hands palm flat on the floor. Well, that's got to be hip motion, right? But she was able to do that. So some patients are, and whether that's soft tissue issues, whether it's proportionality of limbs to trunk, I don't know. There's one other example I would give you, and you mentioned dwarves. We haven't done any of this in kind of neuromuscular patients, and adult neuromuscular patients are another group that I think we really don't know appropriate alignment, and whether fusion is a good idea. And I'm thinking of a gentleman I had that was wheelchair bound from spina bifida and had almost a 90-degree kyphosis. And I looked at his spine and said, well, I can help you with that. And we did a big vertebral resection and restored lordosis. He hated it. He hated it because his sitting was altered and his function from upper extremity to lower extremity was altered in a way that he did not like. So some of that is, and getting back to some of the things we were talking about this morning, it's not just, achieving fusion is clearly one, and stiffness due to fusion is one, but stiffness or effects of function due to alignment is also yet another question that we haven't really delved into. And I should also mention, I didn't have it in here, but we've gone back recently. Alan Daniels has been working with us in ISSG2, and he got the idea of doing an age-related study, looking at our younger patients more bothered by these issues than older, and that turns out to be the case. And I think that also is kind of consistent with most of our personal experience, certainly with my own personal experience. If you have someone in their 40s that you have to do a pan-lumbar fusion on, they still need their lumbar spine. They're still using their lumbar spine in everyday activities. Whereas once we're 60 and 70, as for sagittal balance, we don't need the same level of mobility to accomplish the things we need to, I guess is how to interpret that. But that data hasn't yet been published, but it's coming out soon. Yeah, Peter?
Great job, Rob. Definitely very relevant. My question is, it's a big issue post-op regardless, but other than education and discussion with the patients pre-op, can you quantify before surgical intervention their satisfaction after surgery? Does it work as a risk assessment tool? If they're going to be happy with a long fusion versus a short fusion, or is it more just of a discussion at this point?
I think I don't think we have the same level of prediction that we're now beginning to get with the standardized outcome scores. I don't think we have that, right? The data analytics, and I don't know that we could go back and get it with the data we have to really sift out who are the ones who are going to be unhappy, because there are some. But I think you just have to apprise them of risk. And I think by and large, you can be reassuring by and large in mean values, right? But there are some for whom these are still bothered.
You should be commended on trying to bring something to the community that I think bothers patients below what is picked up on validated measurements. And we run into this problem with cervical deformity because we use a chiropractic outcome measure developed in a whiplash clinic for assessing how disabled cervical patients are. And we use it for every single cervical problem, including deformity, when there's nothing in that questionnaire about eating and swallowing and walking and it's not, so in some ways, the ODI is probably better than the NDI for cervical deformity patients, because it assesses other things. And like your outcome measure has things that people might complain to you in the clinic, but it doesn't necessarily impact the validated scores that people have found to be really impactful, like for SM36. There's 36 questions, but sexual function, is that in there? Perineal hygiene, so for me, when I talk to my patients and I'm contemplating an upper thoracic versus lower thoracic, I can make the x-ray look pretty with upper thoracic fusions. I have more control, but to me, it's the difference between the patient being able to care for their perineum or not. In lower thoracic UIVs, it's the difference between being able to put on your shoes or not. So, how do you counsel your patients about upper versus lower thoracic? And do you try to stop short of that in all of your constructs?
Right. So we did do a subsequent analysis trying to look at question by question were there differences between upper thoracic and lower thoracic endpoints. And the one that came out was the perineal care function. So that may be benefited by stopping short, but it's slight. It's still slight. I mean, it's but there may be a difference there. Outside of that, we weren't able to tease out really any differences between upper thoracic and lower thoracic for any of the domains of our questionnaire. I mean, there'll be some further data coming out. There's a Japanese group, a couple of Japanese groups now that are wanting to use this and have extended it into their population, and I think are going to be generating more data that's 1 and 2 level fusion. So I'm interested to see what they are able to show. I don't know in terms of what more we can do with the data we've got. I think we've diced it pretty much every way you can at this point. But I am interested in cervical stiffness, and we can talk later. One of our fellows last year got interested in developing an analogous tool for the cervical spine, which we now have developed in kind of consensus sessions. I think that very much needs the similar kind of 1 and 2 level fusion data as opposed to pan-cervical fusions, but I'd love to collaborate with you if you're interested in CSRS is starting a registry, which I'm sure you guys are going to be involved with it, and they're going to incorporate this tool as an outcomes questionnaire in that study. So we'll have some better questions specific to the cervical spine, better information, and obviously very different outcome domains in that setting.